Good morning, everybody. Just giving it a couple of additional minutes to let everybody join the session, and then we'll get started. Well, wonderful. Before we formally kick it off, I do have a couple of housekeeping items to review. Thank you so much. This webinar is available both on your smartphone, tablet, or computer, but also by audio. You can join by telephone at the number and using the meeting ID on the slide here. Both closed captioning and ASL are available. You should see our interpreter Tatiana on your screen. And to enable closed captioning, please select the closed captioning icon from your Zoom toolbar and enable subtitles. Slides and the recording will be posted to the California Department of Aging's Hubs and Spokes Network for Aging and Disability webpage. All attendees will be muted during the webinar, but we are saving the final 15 minutes for questions and comments. So you can use the Q&A icon on your toolbar to submit your questions and comments at any time. And if you are joining us by phone, you can press *9 on your dial pad to raise your hand virtually, and we will unmute your line and let you ask your question or comment. If you have additional feedback or think of questions that occur to you after the webinar, you can always email us at engage@aging.ca.gov. This is the third webinar in a series focused on leadership and aging. You can see the other webinars that we've had both on September 15th and September 22nd that explored measuring the success of the Aging Network and AAA partnerships with healthcare, looking at impacts and trends. Those are all available on the Hubs and Spokes webpage. And at this time, I will pass it off to Michael Costa.
Good morning, everyone. I'm Michael Costa, incoming Executive Director of C4A, the state association representing 33 area agencies on aging in California. Our member agencies provide a wide range of long-term services and supports and home and community-based services to older adults and individuals living with disabilities across the state. We're delighted to co-host this webinar with the Department of Aging, given our commitment to take an active role in aging and disability policy development and implementation in California. Part of that commitment involves learning about innovations taking place around the country so that we can adapt and apply those innovations where appropriate to benefit Californians. Today, we have an opportunity to learn from two experts in area agency on aging innovation. Sandy Markwood, who served as CEO of US Aging, formerly N4A, since 2002, has led numerous campaigns to support the needs of older adults with a particular focus on combating social isolation, encouraging healthy aging, supporting caregivers, promoting livable communities, and increasing access to transportation and housing. Sandy has more than 30 years experience in the development and delivery of a wide range of services in the areas of aging, healthcare, human services, housing, and transportation across the nation. Becky Preve was appointed as Executive Director of the Association on Aging in New York, Aging New York, in January 2020. Aging New York is the New York equivalent of C4A. Aging New York provides leadership for the state's extensive aging services network, including advocacy for the agencies on aging to strengthen and expand long-term services and supports for older adults. Prior to this, Becky served as Director of a county area on aging and has been an acute care social worker in Northern New York State. During her tenure as Executive Director, Becky has helped develop, implement, and guide a range of innovative programs benefiting older New Yorkers. Thank you both for being with us this morning. We have much to learn from you. So without further comment, Sandy, it's your turn. Take it away.
Michael, thank you so much. And thank you all so much for having me with you. to talk about leadership and aging. And, I wish I could see all your faces because you are the leaders on aging, not only currently, but you are going to be driving the next generation of aging services. So I'm so excited that California is really intentionally looking at the opportunities for developing leadership and innovation in aging at the community level, at the state level, and we're involved with doing the same at the national level. So in jumping in and looking at what the aging network is going to look like as you all drive leadership in California and in your communities, I have to start with the fact that the pandemic that we're currently living through is really impacted the delivery of aging services. As you all know all too well, you had to turn your services on their head overnight and really readapt the services that were needed as you reached out to not only your current client base pre-pandemic, but also those additional older adults and caregivers that came to you looking for support. Next slide. In looking at that, when we did a survey at then N4A, early on in the pandemic, what we found out is that 93% of the AAAs were already looking at serving more clients than they did before the pandemic. And their existing clients, 69% of existing clients were in need of more services than they did pre-pandemic. Again, this became a perfect storm for the aging network to be able to meet the needs of already growing numbers of older adults that just exploded, and the fact that people's needs were even greater. Next slide, please. In looking at that with the pandemic, and I use this as a framer for where we're going to go from a leadership position with aging services moving forward, what we saw is an increase in the need for meal delivery, for social isolation types of activities, such as telephone reassurance and wellness checks that really dealt with the compounding issue of social isolation, but also just people were looking for information and referral services and supports anywhere at the community level. And as the pandemic went on, caregiver supports, looking at financial assistance, in-home services, ombudsman services and transportation grew as well. Next slide, please. In looking at where the aging network is and how the pandemic really is setting a new stage for aging services, on the top of that list is addressing social isolation, which is now a core component of what ACL and really policymakers are looking at the aging network to do. And again, early on in the pandemic, what we saw is what you reported to us is that 60% of AAAs were saying early on in the pandemic that they were already seeing the negative health consequences of social isolation. And even though we have the vaccine, with the Delta variant and everything else, we know those social isolation issues still remain. And they were there before the pandemic, and they will be there well after. Next slide, please. But also looking at meeting the needs of special populations. And I'm just going to focus in on one, which are people who are living with dementia. 80% of whom, as you know, are living at home and in the community. 30% are living alone. And during the pandemic, before the pandemic, and after the pandemic, there is a huge need for the aging network to reach out to people who are living with dementia, but also people who are living with chronic conditions, people who are living with HIV, and the list goes on. The aging network has always been there, and it is at the foundation of the Older Americans Act to meet those who are most socially and economically in need. And we continue to do that, and that will grow over time, even to a greater extent than it is now. Next slide, please. And I think the other issue that, as we all know, that has come to the forefront at the same time as the pandemic is the focus, the necessary societal focus on racial equity and disparities. And with the increase in the numbers of minority older adults in this country, which I know in California, you see, and you've really been at the forefront of this, is that the aging network, like all society, is looking at being able to be amplifying their response. And so at US Aging, we have had a diversity committee that has been looking at creating more training and technical assistance for our members around being culturally sensitive, culturally competent in program and service delivery, but also at the same time looking at ways that we can be a leader in ensuring that from leadership positions within the aging network, that our leaders are reflecting the diversity of the clients we serve. And certainly as all of these issues come together around the important issue of health disparities. Next slide, please. So as we look at the ways that COVID has changed the aging network, I think where we are from a leadership position is determining how much of these changes, the innovations, the flexibility that we've been given during COVID, do we need to ensure that they remain, and what we need to do to innovate moving forward. Next slide, please. And the other issue that has really come to the forefront, which I believe is a huge opportunity for the network, is our partnerships with healthcare. And I know through previous sessions, you've already talked about healthcare in general, but I think what we've also seen is a huge opportunity around solidifying our role with public health. And I'll go into more on each of these issues as I talk further with you this afternoon. So the other issue is social determinants of health and solidifying those partnerships with healthcare, which again, recognizing that the aging network collectively has been in the throes of responding to the needs of older adults, people with disabilities, and also caregivers around social determinants of health for nearly 50 years. So this is a leadership role that we have, and we, again, need to expand and enhance. Next slide, please. So the question for the aging network and from a leadership position is, with all of these changes, what's next? What's going to come when we get on the other side of the pandemic? And again, to determine that, US Aging reached out to our members and asked the question, what are the greatest challenges that AAAs see for older adults and caregivers related to COVID-19? And you see here that by far, the highest challenge that was reported was around social isolation of community dwelling older adults. Other issues around technology, both limited access, especially in rural areas, which you have in California, but also technology training, caregiver supports, food insecurity, transportation, abuse, neglect. And what we're seeing is a huge, really focus on mental health and behavioral health issues. Next slide, please. And then we also asked, well, you know, is COVID just an episodic event, or is it really going to change the way that aging services are delivered in the future? And what our members told us is 99% said it will have an impact. 50% said a significant impact on aging as a driver for aging services and supports moving forward. Next slide, please. So in looking at the challenges and the changes related to COVID-19 for the aging network, because I think this really goes beyond just AAAs, and I know that we have AAAs, but others on this call, is really, again, how we balance of the world of virtual that we entered into overnight with what I think is the sweet spot of the aging network, which is our in-person, in-touch, person-centered approach to meeting the needs of older adults, people with disabilities, and also their caregivers. And also, again, looking at how we're going to do things differently, whether it be congregate meal sites, you know, are we going to be able to keep the grab and goes? Are there other, and the restaurant arrangements that many in the aging network developed during COVID? But also, as you look through this list, you'll see a number of issues that were raised around workforce issues within AAAs within provider agencies, with the lack of volunteers, many who left during COVID and have not come back. So during this time, we have a lot of opportunities for growth, but we certainly also have challenges that we need to confront at the same time. Next slide, please. But as we look at confronting these challenges and opportunities, the one thing that also came to the forefront during COVID was the opportunity to partner. And, you know, the Aging Network has always built its services and supports on reaching out and partnering at the community level. And the same held true during COVID. And in fact, it increased. 3/4 of the AAAs developed new partnerships, whether it be business partnerships with healthcare and healthcare entities, or other types of contracts with organizations to be able to move forward. And that's something that we need to continue to build on. Next slide, please. So as we look at what I believe Aging Services 2.0 is, when we look at 2022 coming up and looking at hopefully coming out of the pandemic and how we redefine and reimagine our services moving forward. I just wanted to give you my crystal ball and also give you some examples of ways that area agencies and other aging providers across the country are using this opportunity to innovate and how these innovations may stick in the future and actually enhance and grow aging services and supports. So next slide. So what will aging services look like? Well, I think the first thing that we need to tackle is what I mentioned before, new ways of delivering services. What are the hybrid models of services and flexibility that this network needs? What we know from evidence-based programs is we got a lot of older adults who were participating in evidence-based programs that didn't want to come to an in-person site. However, at the same time, we know, again, the sweet spot of the network is not just delivering a meal, but actually going and checking in the refrigerator to see what's in there, to checking on people's medications, to actually connecting with them. So how are we going to come up with both the best of that in-person model with the technology and the virtual platforms to be able to expand our services and supports, given the fact that, as I said at the beginning, we're serving more people and more people with greater needs than ever before. And in saying that, AAAs across the country and aging service providers are looking at that balance of determining how that will come together. And I'll have several examples of that. Social isolation and engagement, again, core service now. And in looking at social isolation during COVID and turning on a dime, this is tied to the next bullet on technology and recognizing the fact that when we went into the COVID pandemic, it wasn't just that clients didn't have the technology, it was also that our staffs didn't have the technology. And with the COVID relief funding, hopefully that is turning that around. But in looking at social isolation and engagement, and technology is recognizing that many of the clients that you serve, their telephone line, their landline is their technology. So we have developed and collected through Engage, the National Resource Center on the social engagement of older adults, a variety of different opportunities to telephonically connect to older adults, whether it be beyond telephone reassurance and wellness checks, to actually doing activities and engagement, book clubs, coffee clatches, other things using the telephone, but also recognizing that this virtual world has also opened up a bigger world of social engagement opportunities. And we have partnered with OATS, Older Adults, a service out of New York, and Becky knows well that group that is looking at not only offering opportunities for technology for older adults and the agencies that serve them, but training as well. So we've engaged with them to be able to expand the opportunities that the Aging Network has in this space. But in looking at that, also recognizing that telehealth has also grown during the pandemic, and many AAAs have stepped into that space to be telehealth navigators for older adults, helping the healthcare sector to be able to actually operate those telehealth services and supports with older adults who didn't either have the technology or didn't know how to use it. And we've also been engaged in the healthcare sector by managed care organizations to do social isolation activities to be able to combat social isolation through a whole variety of health and wellness outreach efforts and activities. Additionally, investing in home and community-based services and recognizing that this has become a top of mind issue for policymakers, but also for families who want to keep their loved ones at home, and recognizing that home and community-based services are an economic driver. And there have been a number of AAAs, the Atlanta Regional Commission, the AAA in Kansas City, who have actually done economic studies of the value of home and community-based services in keeping older adults living at home and in the community. So it's expanding the services, talking about the value, but also talking about the value, the economic value to the older adults and caregivers of supporting people living at home. Emphasis on age-friendly and dementia-friendly communities. If we're going to focus on home and community-based services, we have to focus in on having a community that supports older adults and people with disabilities and their caregivers. And so we at US Aging are administering Dementia Friendly America, which is a collaborative looking at ways to encourage communities to respond and really support people and their caregivers, support people who are living with dementia and their caregivers, and also working with the AARP on how this blends in and balances with the age-friendly movement. And what we found in the states of Arizona and also looking at Massachusetts, they've blended in age-friendly and dementia-friendly efforts and combined those as a community initiative moving forward. And in doing so, have really put at the forefront the opportunities to encourage more stakeholders to be able to do both. And it's working very well. But looking at dementia friendly, this has been a prime opportunity to engage businesses in being dementia friendly, and also engaging the faith community in developing memory cafes. And we have examples of all of those and more on the Dementia Friendly America website. Greater roles in transportation and housing. Well, that is an age-friendly community. You can't have age-friendly if you don't have transportation options. And both on the rural front, because I know in California, there are a lot of rural communities, the Appalachian Area Agency on Aging has partnered with PACE to be able to expand in a rural Appalachian portion of the state of Virginia to be able to expand their medical transportation to include people who needed to go to dialysis and cancer treatments, and in working in a coordinated way with PACE have been able to do that and expand those efforts. But we've also been working with other different AAAs. In Connecticut, the AAA is working with an organization called Trusted Rides, which is providing chaperone transportation, again, to medical types of appointments or hospital visits. So there's volunteer driving opportunities that have come up even during COVID. And the National Aging and Disability Transportation System has a whole best practices cadre that you can repository that you can to link into to find out more. And on the housing side, just in California, I know this is a huge issue, but it is a growing issue across the country, not only finding affordable, accessible, and supportive housing. And to that end, the Administration for Community Living has launched recently a housing and services resource center that N4A is pleased to be helping to administer, to really dive in deeper, to bring the housing resource leaders together with aging and disability to look at new ways to be able to expand the housing services and supports. Currently, we have a range in the aging network. We have the Northeastern Ohio AAA that actually runs and operates a whole series of multifamily supportive housing for older adults. Home modification, but we also have a number of AAAs like in Loudoun County, Virginia, that has jumped in, started during COVID to be able to respond to the needs of homeless older adults, which is growing, an issue that is growing across the country. And in Pima County, Arizona, they have started a huge effort around finding affordable rental housing for older adults that live there. Next slide, please. Also, the huge emphasis on caregivers, and with the fact that the RAISE family caregiving report just went to Congress a week ago, we are expecting a lot more to be happening in that arena. But the Aging Network has worked in supporting caregivers for a very long time, and innovations are coming up in Fairfax County, Virginia, which is an urban area right outside of Washington, D.C. They started a blending caregiving with technology to develop a caregiving alert program that alerts caregivers of resources and issues in the community that they need to know about. And that is being replicated in other parts of the state. The focus on investing on aging workforce and volunteers. I was just in Oregon meeting with a strategy session with all the AAAs there. There were some AAAs who were down staff 25%, and we're having a hard time finding additional staff to fill those positions. So we are working with the Administration for Community Living, looking at ways to be able to use your COVID money to be able to look at ways to be able to enhance and expand not only the aging workforce, but also to look at ways to be able to expand the volunteer workforce. And N4A is working on, N4A, US Aging, is working on a number of different pilot projects with some local foundations on ways to engage newly retired individuals into supporting the work of nonprofits at the community level, but also AAAs. And again, partnering with healthcare, and I know that our next speaker, Becky Prevey, will go into that in detail. We had the opportunity to work with the New York AAAs on partnering with healthcare, but we're seeing a huge uptake in the interest area of partnering with community-based organizations. The catch there is making sure that the community-based organizations, AAAs and others, are also being reimbursed for that model. And we will soon be coming out with a survey that will also highlight examples of ways that that is happening through an RFI survey that we just completed at the end of the summer, which is showing that even despite COVID, there is a lot of interest and maintaining growth in the area of partnering and contracting for payment with healthcare, and also partnering with public health. The work that the Aging Network did around the COVID vaccines, I think, has really put the Aging Network on the map. CDC, as well as the Health Resource Services Administration within HHS at the national level, is now interested and looking at ways to fund the work of the Aging Network in this public health space. And so there's a huge opportunity. We've seen public health contracting with AAAs. We've seen public health working with AAAs at the vaccine sites. So this is an area of growth and leadership for the network moving forward, as is working in the area of racial and health disparities. And we'll be coming out with a whole series of examples of the way that the network is working and expanding their work in the space of diversity, equity, and inclusion, but just highlighting commitments and policies at the AAA level, but more importantly, also looking at ways that services are being redirected to ensure that they are culturally competent and culturally sensitive, and also ensuring that there are contracts a greater degree of contracts with more grassroots neighborhood organizations that represent the communities of color and diversity that the network is serving. So there are opportunities here. Next slide really quickly. And I know I've highlighted just a few of the best practices, but I want you to know that at the US Aging website, we operate the National Aging and Disability Transportation Center. There are best practices there that you can draw upon, or you can just call the staff. Dementia Friendly America. Again, we have a whole repertoire, clearinghouse or hub of best practices. Engage, the Engaged Resource Center for promoting the social engagement of older adults. We have tons of resources there on best practices that run the range from telephonic to much more sophisticated utilization of technology. And there are more, but I just really want to let you know that from US Aging's perspective, we see you as the leaders of aging moving forward. We're here to support you, and the current and future generations of older adults, people with disabilities, and caregivers are counting on you. So we're here to help you be the leaders that I know this country needs and California needs for older adults moving forward. So with that, I will say thank you and look forward to answering your questions.
That's great. Thank you, Sandy. Becky, let's turn it to you.
Thanks so much, Mike. And thank you, Sandy. It's always so wonderful to get the national kind of lens of things. And to everyone in California, I just want to let you know, I've had the pleasure of meeting Mike a couple times now, and just so excited to have him as a colleague, really to move California forward. And I'm just really excited to be here. I apologize in advance. I talk extremely fast, and I did provide a fairly lengthy slide deck. Not because I want to go over that in detail, but really I wanted to leave this group with some information to kind of go back and look at how we frame aging in New York State and what has been successful for us. So the presentation today is going to talk about how to better connect hospitals and health systems. I'm also going to talk about some best practices because I think that fits very nicely into what Sandy has shared and a lot of what we're seeing across not only New York State, but nationally. Next slide, please. So if you take a peek at New York State demographics, this isn't going to surprise any of you. New York State is actually 4th nationally in those over the age of 60, but we're seeing probably what you're seeing in California as well. Family structures have really changed as far as married couple families, adult children who are able to be caregivers, and we're seeing a very significant increase in those single parent households, non-traditional households. And then when you look at the number of counties within New York State and where we're headed in the future, we always like to do a level set with this. I use this very extensively with the New York State Senate and Assembly members to talk about, what's going to happen in your district moving forward, and really just kind of sets the tone for what New York State is looking at in the older population and how we can better serve them. Next slide. Our customers, obviously, I should take a step back. I represent the 59 area agencies on aging in New York State. We're the not-for-profit membership arm. We work extremely closely with our state unit on aging and their director. We pretty much talk at least twice a week to make sure that we're on the same page and that I'm representing, my membership. And we're also meeting any federal or state requirements. So the data that I'm going to share with you is New York State Office for the Aging data that is collected. And I am able to share. So obviously, we're going to talk about high risk, high cost individuals, those with chronic health conditions, functional needs. This ties directly into what I'm going to talk about on the healthcare lens of things. And you can tell that when you look at the top 5% of Medicare spenders, where they fall, those are the people that we are serving. When you look at chronic conditions and functional limitations, that's the population that we're serving as well. So this is kind of just a picture of the type of customer we're serving and what that means to the healthcare system. Next slide. Again, when you look at chronic conditions, they are singled out as the major cause of illness, disability, and death in the United States. You can see those 65 and older. We have about 35% of them who are living with some type of disability. So a fairly significant portion of the population. When you look at the cost of this to the healthcare system, that's really where our advocacy comes to play. Because how can you sell our services and ask for an investment in our services if you don't have something to counteract that investment? Well, obviously, when you look at the cost of chronic health conditions being $864 billion by 2040, you're talking about significant cost savings if you can invest on the prevention side, which is exactly where your strong suits are as far as addressing social determinants of health, which Sandy talked extensively about. Next slide. When you look at the nursing home risk indicators, these have been long established. We actually use these to talk about our population. So obviously older individuals, lower income, health conditions, cognitive impairments, if they've utilized healthcare in the past. So when you look, at the number of individuals who did have to use a hospital or a nursing home in 2009, and those that had nursing home stays, again, this stacks up to the cost of caring for the population and why it's so important for us to receive these investments. Next slide. I'm going to go very, very quickly through these. Again, if any of you want further information on how to capture this data and then share it, this has been very beneficial for us. It's very easy to sit in front of an elected individual or in front of state government and say, look at the average age of our customer. I can tell you globally, the traditional age of our home delivered meal recipient is an 83-year-old female who lives alone, who has 4 or more chronic conditions and has deficits in activities of daily living, and actually meets those nursing home criteria that we just talked about. So very high cost individuals that are receiving those services, and we're able to aggregate the data on how long we're able to serve them and what the cost is for our system. Next slide. This again just walks through those individuals, what their deficits are, and these are all registered clients, so they're receiving cluster services. And again, data is very, very powerful in the work that we're doing in New York State. I'm sure it's also successful in the state of California. It seems to be something that people pay attention to, on top of the anecdotal stories that we're able to share on what we did throughout the COVID-19 pandemic. Next slide. Again, these are just talking about those customers, the number of individuals that need the service, what their activities of daily living looks like. Again, it's really easy to talk the language of, when you look at our personal care program, almost 92% of the people that we serve need help taking a bath. That's real information that you can utilize to talk about the type of client that you're serving in home and community-based settings. Next slide. Again, this is for your reference. Next slide. I think chronic conditions is something that has kind of become a really hot topic when you talk about social determinants of health. Obviously, chronic conditions are lumped into those individuals. And when you look at our customers, it's overwhelming to see the number of people that fall in that 6+ category. So these are very complex medically patients who we're serving at a much lower cost than the healthcare system. But it's also very important to note, when you're keeping someone in their home that has 6 or more chronic conditions, you are absolutely touching on a medical model, even though that's not where we're predicated. And this is something that we have absolutely utilized in our conversations with managed care organizations or health plans to talk about just how intense this customer is that we're able to serve in homes and communities. Next slide. Again, this just talks about those types of chronic conditions. None of this is going to be anything new to you as far as, blood pressure, diabetes, hearing impairments, so on and so forth. So this is just really a picture of those clients that we're serving. Next slide. So this is where I get really, really excited, is when we talk about the network infrastructure. And yes, this slide is a little funky, so you have to keep clicking. New York State is a little bit different than California. We have 59 area agencies on aging. We call them offices for the aging. We have 2 Native American Indian reservations that also have their own specific AAA. We work with almost 1,200 subcontractors. So not unlike many other states, we subcontract a lot of our services out. And you can see we have a fairly robust senior center congregate meal site, as well as having the largest nutrition program in the country, which is something we're very proud of. Obviously, that includes New York City region, which has a very, very large footprint in New York State. We also provide 41 of the highest level evidence-based interventions through those AAAs, which I'm going to talk a little bit more in detail about when you talk to health systems, why that's important. We also use a variety of volunteers for the long-term care ombudsman program and our health insurance counseling program. And we do a couple things that are really innovative in New York State. So we actually require all case managers and all of our health insurance counselors were mandated by law to be state certified. So case management, those are all certified through Boston University of Social Work through a contract we have with them. And that's been very beneficial in my conversations with health plans because I am presenting a array of services through certified case managers that are going to look the same here in Northern New York, or if you're in Brooklyn, which has been very beneficial. Next slide. Again, many of you provide all of these services. Not going to be new to anyone, but it's very enlightening to me at times when I'm speaking with individuals that think that the AAA only does meals. You know, that's just this undertone of, well, we thought you just did home delivered meals, when really we have such a variety of other services and supports. I am going to talk very briefly on this slide about some innovations because I think Sandy raised some really good things. We've actually done numerous partnerships with the state of California, including Get Set Up, where we purchased 100,000 online programs to distribute to the network in New York State. We're also working with GoGo Grandparent to expand transportation services because transportation is such an issue here. We've done a lot of work with virtual senior centers. Sandy touched on the Older Adults Technology Solutions platform, which has been really, really wonderful and has provided hands-on assistance to older individuals who wanted to learn about technology and technology supports. We're also looking at replicating a home share pilot project, which has been stood up in the neighboring state of Vermont, where young professionals who are dealing with the housing crisis are partnered with older individuals who need a roommate through a vetting process. So again, really exciting things kind of happening in New York State as far as the innovations. And as Sandy said, we're going to look a lot different coming out of COVID than we did going into COVID. And then lastly, on the innovation piece, we have really been very lucky. New York State Office for the Aging has invested significantly into the animatronic pet project, which Sandy shared some pictures of different AAAs that had done this. We've actually distributed about 4,000 cats and dogs throughout New York State for people that were suffering from social isolation, and it's been hugely successful. Next slide. Again, our comprehensive assessment and our plan of care includes many of the things that you're all screening for. We additionally have added what's called a tech check due to COVID-19, so we can get a sense for how many individuals have internet access, how many are really comfortable with accessing technology. We've also added in a loneliness and isolation scale. That's the DeJong 6-point questionnaire to really see if someone is feeling isolated or lonely. And that's actually the scale that we used during the PET project. And over a 1-year period, we saw a 70% reduction in feeling of isolation and loneliness by adopting one of the animals. So again, data is really powerful. And these are the types of things that we make sure that we're gathering in New York State. Next slide. To talk about some innovations, what I wanted to do was really get some raw data in front of you on how you can talk the healthcare language. And I know when Mike introduced me, he shared I was a hospital social worker, so I was responsible for discharge planning and really put me in a good position as far as advocating for our network and the fact that the brunt of healthcare responsibility really falls on community-based organizations such as yourselves. And traditionally, we did not get reimbursement for those programs and services, which is absolutely where we need to go in the future. And so we had the opportunity a few years back under the Balancing Incentive Program to do a couple really great innovations where we were able to get data back. And this has been really successful in my conversations with many of the large health insurance payers in New York State, because you're showing your return on investment. So in Erie County, very basic program. Really worked with hospitals and skilled nursing facilities to try and bridge those gaps, connected to community services to make sure that there was a warm handoff to any waiver programs or PACE programs. And at the end of that pilot project, we saw a $3.41 return for every dollar invested into the project. So really clear-cut data. And I can share with anyone that's interested further information on these pilots. And how we got there. But again, really, really good data. In Monroe County, we did a very similar thing with primary care physicians' offices, really just linking social work services and then those highest level evidence-based programs, as well as some home safety and minor home modifications. And I just think that this data leaps off the page. So you saw a decrease of 50% in hospitalizations in the first 90 days and 65% over 180 days. The return on investment for this project in Monroe County saved almost $5 for each $1 invested, which was a $2.8 million savings. And this is actually the study that we're using with the major insurance payer in Monroe County and the 37 surrounding counties for them to actually pay our case management staff to provide wraparound services for their members. Next slide. The self-help active services aging model, self-help, I'm going to share with all of you. It is an online virtual program that we're also rolling out through COVID-19. This was prior to the pandemic, but we looked in Queens, New York to really look at benefit and entitlement assistance, wellness programs, health screenings, care transitions, referrals, and volunteer opportunities. So again, these are all things that are already in your book of business and that you're doing, but how do you aggregate the data on the return on investment to make sure we receive ongoing funding? And again, when you look at the cost for a self-help customer versus a Medicaid customer, the cost reduction was huge. Next slide. I wanted to show you this slide because it really talks to exactly what I've alluded to, which is how much does it cost us in New York State to provide these services for individuals. And again, this data is really powerful because when you look at those nursing home risk indicators, these individuals on paper qualify to go to a nursing home. And you can see for our PC level 2, which is that hands-on in-home care, our average cost is under $7,000 per client per year, versus about $150,000 for that member to actually go to a skilled nursing facility. The reason this slide is so important is because in the last budget cycle, I was able to advocate, work with the governor's office and the Senate and Assembly to aggregate the number of people waiting for our services, what the cost of those services were, versus what the reduction in Medicaid state share would be if those individuals went to a skilled nursing facility. And I can tell you, we got an additional $8 million over and above what we traditionally received in the budget to address those wait lists. And, was very, very powerful for us to do a snapshot of our high intensity customer, how much it costs to serve that customer versus what it costs to the healthcare system in a state that has a 50% Medicare share or Medicaid share. Sorry, next slide. Again, these are our non-registered services, transportation, et cetera. Really, really powerful data when you're talking with health systems. Next slide. A couple practical examples, and then I'm going to wrap up because I know we're fairly short on time, but I think it's really important to be able to highlight either within your own AAA or from a state perspective that you guys do successful discharge planning. You divert from emergency departments, you reduce social admissions, you increase patient satisfaction and partnership. And a lot of people question me and say, well, Becky, how are you increasing patient satisfaction? And what I always say is, if your local hospital is telling an individual you don't belong in the hospital, you're going to be in observation status, or you're going to be in admission denial, it's very easy for clients in the community or patients to say, that hospital was a horrible experience for me and I don't understand it. But when you have the community-based organization on the other side, solidifying those changes in Medicare, observation status, why you need to be acutely ill to go to a hospital, it absolutely changes your patient satisfaction on the back end. And then again, community interventions that address social determinants of health is absolutely what all of you do on a day in and day out basis. Next slide. The social determinants interventions really allow support in the community. We're low cost, high yield services. We increase healthcare outcomes and we actually enhance medical interventions. And when I go to the next slide, I'll talk about this a little bit more in actual experience in successful discharge planning. So again, AAAs, you provide transportation, meals, PERS. These families, you sit in their living rooms and you talk, that what a hospital or a primary care physician is being told doesn't always match what you see when you do a home visit. And so this is a perfect example, very complex, medically frail individual, numerous admissions in a very short period of time. Kidney disease and heart disease are two of the most difficult issues to treat jointly, just because treatment for one exacerbates the other. And again, this individual was not having a good healthcare experience. Through a referral to the AAA with case management, implemented services. There were numerous, conversations had in that living room. Out-of-state relatives became involved. And instead of that individual coming back to the hospital or going to a skilled nursing facility, they were able to come up with their own care plan, their directives, and ended up passing away at home, which was a victory for this family. Next slide. The other thing I wanted to highlight really quickly that was very, very successful in New York State were our emergency department deferrals program. This was something I actually did prior to coming to the state association. I stood this up with my local EMS. We trained all of the 911 dispatch staff. All of our client information with consent was uploaded into the EMS system, which meant if one of my clients called 911, the dispatcher in real time would see this client has a cognitive disorder. The key is under the back mat. Contact the son. This individual may be confused. They may have a dog. And then if an individual called in for caregiver breakdown, out of fuel, feeling confused, instead of dispatching state police or EMS in a very rural part of the state, I would actually get paged in real time by dispatch staff to come up with a solution. And this was hugely successful, especially with caregivers that felt really burned out and would call 911 and say, I can't take care of mom anymore. And if they had an instant referral to the AAA where I could say, we will do a home visit tomorrow to come up with a plan. Do you feel safe for tonight? 9 times out of 10, the response was yes. If someone can get to me tomorrow to come up with a plan, that is my preference. So it was very beneficial for the hospital as well as EMS. Next slide. Again, we talked about Medicare covered services. You are the trusted source of information. You provide the community interventions. You are able to apply for a variety of services in the community, and you reinforce the healthcare system landscape. And I think many times it's difficult to highlight your own successes and all the amazing work that you do. But again, we're moving in a different direction post-COVID. We have been thrust into the spotlight. We are known and trusted for these services. And this is a mechanism for us to continue to get paid for those services under a medical model that we have been, relatively shut out from for years. Next slide. Again, patient satisfaction is really important to hospitals and their payer sources. It's important to you at your AAA. You guys understand family dynamics, how to talk about treatment options and follow-up. And you're also a patient advocate through a healthcare experience, whether that be advocating for someone to actually go to a skilled nursing facility or to come out of a skilled nursing facility. You guys are the trusted entities in the community that provide those services. Next slide. So I just want to say thank you very much. I'm sorry that was so kind of quick, and I know we wanted time for questions. I would offer, if any of you want further information from me on how we got this data or how we implemented it, I welcome you to reach out. So thanks so much.
Great, thank you very much, Becky and Rebecca. This is really informative. So we've got a couple different lines of questions here. One I call housekeeping questions, which is really how do people get the slides that have just been presented? I think the answer is on the CDA Hub and Spokes website. We'll put it up on the C4A website as well. And then the other question is they're kind of specific around, pilot project data, information on social isolation and what might be best practices to address social isolation that goes beyond telephone interaction. Is that something that people can reach out to you, Sandy and Rebecca, on?
Well, I'll just jump in, Michael, is through the Engaged Resource Center. If you just go to US Aging and hit the Engaged Resource Center, we have compiled information on addressing social isolation, again, from telephonic all the way up to using a much more sophisticated technology, and you can see everything in between. And we also separated it out from urban, rural, and the like, and give you contact people for people who you can follow if you want to replicate the program. Okay.
So the now comes the thought question. For those of us who are, we don't have the deep data bench that you have in New York. I mean, it's very impressive. You've got data to show you can reach out to managed care and have a discussion. And in California, we're sort of not in that point yet. So what do you think are the most important elements to bring to a conversation with managed care, absent having that kind of specific data? We're gonna try to get there, but we're not there yet.
I personally think that the thing that AAAs sell themselves short on are, you guys are the experts. And so when you go to a health plan or you go to a hospital, I've heard from colleagues that said, I just really felt intimidated and I don't know all this medical jargon. There's a huge difference between knowing that medical jargon and talking through what I just did. We're in the homes. We're the eyes and ears of medical professionals. We know these clients inside and out. We know if there's food in the refrigerator, like Sandy said. We know who the family caregivers are. We know if the house has fuel oil. We know if there's 5 years of medication sitting in the cabinet. That's all you need to know when you have these conversations. All of you are providing the highest level evidence-based interventions, chronic disease self-management programs. All of those are already proven with their efficacy. Sorry. So I think really just having the confidence to have these conversations and to open it up to say, how can we partner? And, I talked about a pilot that we're doing in Western New York. We're also doing one in Columbia County, which is a rural area. We're actually doing a pilot where we embed case management with a local hospital system and primary care physicians' offices and public health to facilitate telehealth conversations. And so I think when you're able to just talk about the value of the work that this network does, and how frail the individuals that we're serving with those core services are. I never want to talk about negative aging, but when you're talking to health systems, you're dealing with people that have a lot of chronic illnesses, that have a lot of acuity issues, who you can support in your communities. And, one of the health plans we talked to pretty much said we would go bankrupt if we weren't having our eyes open to this conversation on how we can partner with one another. So with the changes in healthcare restructuring, hospital systems and payers want to have this conversation. And what you need to know going into those meetings are you guys are the experts. You know what you're talking about. They don't know your language. So that would be my one takeaway. And if, Mike, if anybody wants to talk to me about what we've done with health plans and how we've presented it, I would welcome that. That wouldn't be a problem.
And Michael, just following up on Becky's comments, also as far as having information on how to have those conversations with healthcare, what's your elevator speech? How do you sell yourself through the Aging and Disability Business Institute? We have a lot of background data and best practices like Virginia Cares, which is a network that has formed in Virginia, housed in a very rural AAA, but focused in on selling the AAA services to managed care. And what they went into, just like Becky said, is they went in saying, let me tell you how many certified INR specialists, how many nurses we have, social workers we have. They went and made the business case for the work that they do every day. And as Becky said, with a lot of these managed care organizations, they don't even know where the dirt roads to go down to find these people, much less wanting to do that. And these are people that and trust you and will open the doors to you, and they won't to them, and they know it.
And Sandy, just to tie into that, huge plug for US Aging, which I'm still trying to get used to, so I apologize. The process we went through with them for business acumen was it got us to a level playing field because it got all of the directors at the same space. So I'm sure California is this way as well. You might have different people with different strengths. Business acumen in that process got everybody talking the same language and working through those items. And it was hugely beneficial to New York State in having those conversations because we are such a large state, as is California. So if you're all talking the same language, it's really important. And, I think Sandy, you hit the nail on the head. I said to the chief executive officer at one of the health plans, you get dinged on every individual over the age of 50 that doesn't get their colonoscopy. And he was like, yes, absolutely. That's a huge issue. I said, I'll knock on their door and have them get their colonoscopy. And it was a game changer. And that's what you guys do as a network on a daily basis.
Great. So one last question. Do you see or foresee a future, either of you, where AAAs are part of a large provider network that ranges from self-care all the way to hospice, involving social service providers and healthcare providers, so that you're really, I kind of call it a services follow the person approach, where, you know, you actually track the trajectory of someone and given changes in health status and functionality over, you know, over their lifetime, at least their aging lifetime. Do you kind of see that kind of a network evolving?
I'll just jump in really quick and say yes. And in saying that, you know, I think that we've got the foundation and infrastructure to do that now, because we help people when they are with healthy aging, and more we are looking at end of life and advanced planning. So it only makes sense as the trusted resource for us to carry that lifespan approach. Becky, I'll let you jump in.
And Sandy, you knew we'd be on the same page with this. And I think, you know, I know we're short on time. I think the one takeaway from this, and I was remiss in not mentioning it, you have to look at the lens of the individual receiving this on the other end, right? Like that's our goal. That's why people are in human services. And how do you want that process to be for you? I don't want to talk to 15 case managers and not have any of them talk to one another if I have a chronic illness. I want to know that there is this system that is user-friendly, that keeps me out of the hospital, that respects my wishes on how I want to age. And that's exactly what you just talked about, Mike, is that beautiful utopia of, you know, let's all get out of our own spaces, work with one another within our own confines, but to make sure that we're doing that holistically. And I really feel like that's where we're moving. And it wasn't easy to get here. Breaking down silos is never easy. And the changes in healthcare have been very rocky. You know, New York State was a DSRIP state. I could go on a dissertation about that for the next 3 days. But basically, we're all getting pushed to keep people in homes and communities successfully at the lowest cost possible. But at the end of the day, doing that is going to be the best outcome for the individual receiving the service. So that is my vision.
And the only thing that I would also add, Becky, and that was wonderful, is we work with the individual and we work with their families. And there's growing recognition of the importance of family caregivers in an individual's health and wellness and well-being.
Great. That's great. Thank you very much. We've kind of reached the end of our hour, and it was a quick hour, actually. So there are a few more questions in the Q&A. I think it's safe to say that the webinar organizers will look through those questions and we'll figure out a way to get a response to you directly for that.
Wonderful.
Wonderful. Thank you.
Thank you both. And I'll turn it back over to the webinar folks.
Thank you, everybody. Well, thank you for joining us. And we're gonna wrap up and follow up with folks who submitted questions that we weren't able to get to. If you have any other questions or comments that you'd like to share with us that maybe you didn't get a chance to submit through the Q&A, you can always email us at engage@aging.ca.gov. Thank you so much.